With reading our board mission. I'm going to add our board philosophy for this meeting. So the mission of the board is the statutory mission of the Texas State Board of Pharmacy is to promote, preserve, and protect the public health, safety, and welfare by fostering the provision of quality pharmaceutical care to the citizens of Texas through the regulation of the practice of pharmacy, the operation of pharmacies, and the distribution of prescription drugs in the public interest. The philosophy is that the Texas State Board of Pharmacy will assume a leadership role in regulating the practice of pharmacy and act in accordance with the highest standards of ethics, accountability, efficiency, effectiveness, and open communication. We affirm that the regulation of the practice of pharmacy is a public and private trust. We approach our mission with a deep sense of purpose and responsibility. The public and regulated community alike can be assured of a balanced and sensible approach to regulation. So I'd like to welcome everybody that's here. We do have two new members, Rick Tisch and Donna Monomar, and I'd like to welcome them to the board. We would like to ask everyone to please silence your phones, keep side conversations to a minimum. We know that we've got a pretty full agenda with a lot of topics to discuss. And with that, I know we have some new staff members, so we can introduce them.
Right, Raul Pacheco, you'll be seeing him later. He is our new accountant, and he will be going over our budget information with you when we get to that item. He's not here right now, but he will be here in a little while. And he has 17 years of state experience. He has a degree in accounting from Texas State, and before he worked for us here at the Board of Pharmacy, he was with the Texas Medical Board in their finance department, and so we're happy. He's been with us for several years before our previous accountant left, and so he's been promoted to that role, so we're excited to have him stepping up into that position.
All right, well, first of all, we have a new attorney in the legal division. Victoria Sanchez, right here. She has a bachelor's degree in finance and international business from Florida International University and a master's degree from Troy University in Alabama, and then she has a law degree from the University of Miami. So before law school, she worked for Eastern Airlines, that's a long time ago, as a transportation analyst and customs broker, and then after law school, she's worked for legal services in Alabama, Georgia, and Texas for 14 years. She was part of the Army Judge Advocate General Corps for 5 years of active duty and 7 years of Army National Guard. She worked for Round Rock ISD Legal Services, and then most recently at HHSC. She has one daughter that lives in DC, and she lives in Georgetown with her husband. He's a retired Army aviator. And we also right now have an undergraduate student, Haley Gray, here. She is currently in her last year at the University of Texas at Austin, working towards her BA in Government and Russian Studies and getting a certification in National Security. And she hopes to attend law school after graduating from undergrad and eventually work in the field of international business litigation. And we're excited to have her here as an undergraduate with the legal department. And then we also have a new receptionist. She didn't come over. Her name is Estella Casares, and she previously worked for the board for about 11 years and then retired about 2 or 3 years ago, and now she's come back. She also worked as a receptionist before and then in licensing, so we're glad to have her back, and she's doing a great job for us already, so jump right in.
And Misty.
So the licensing division is proud to announce that Helen Wilkerson, sitting over here, has joined us. She is going to be the license and permit specialist that handles change of PIC, change of employment, fingerprint requests, as well as technician pharmacist name and address changes. She comes to us with pharmacy technician experience from CVS Pharmacy, and Helen has a BS in biology from Stillman College in Alabama.
And Ben, I believe you have an intern to read.
Yes, we have a pharmacist intern that just began, just joined us yesterday, Miss Dorothy Tran. Dorothy, she's a fourth-year pharmacist intern from the University of Texas at Austin. Today is her second day on rotation, and she attended Baylor University, and she earned a bachelor's degree there in international relations, and later graduated from the SMU Dedman School of Law in Dallas. After practicing as an attorney for a short period of time, she decided to go back to school and attend pharmacy school at UT. She loves Austin and walking in the trails with her husband and 2 dogs and exploring new restaurants. So welcome, Dorothy. Thanks.
All right, this will be a one-day meeting. We'll take a break between 11:45 and 12:30. We do expect that we will, again, end in that one day. And I believe that you have an announcement as far as continuing education.
Continuing education credit is available for attending the entire board meeting. Please be sure that if you want to claim C credit, that you signed in on the roster at the table when you check in. We will then check at the end of the meeting who's here, and the certificates are emailed to you several weeks after the meeting. So make sure that you printed your email address clearly so that we can get it to the right email address. Board members, you do not have to worry about that. We take care of your CE certificates. We know you're here, and we'll get them to you.
Okay, we'll start with the agenda. The one thing on the agenda is that regardless of where we are in time, at 1 o'clock, we will have our PRN report. So the first item on the agenda is the discussion and approval of minutes. We have the minutes from our August 6th meeting, as well as temporary suspension hearings from August the 7th and August the 28th. We can review those and then have a motion to approve.
Move for approval of the minutes.
Lori approves, Donald seconds. All those in favor? Any opposed? The minutes will be approved as posted then. With that, we'll turn it over to Megan to look at the final adoption of rules.
I just want to make sure everyone knows that you do speak into your microphones. You need to push the button and turn the green light on. We are trying, this is our first time to stream the board meeting so people can watch it at home or wherever they are. So it is, we did some test runs, and it is kind of hard to hear if you don't speak directly into the microphone. So just try to remember that so that the people that are streaming can see it as well.
So on the left-hand side of your rule PDFs, there are bookmarks with links to the lines that have edits on them. And then also for the rules for adoption, there's a folder on each of your laptops with the orders for adoption and the rule preambles. And then there is a green folder with hard copies of the orders for the adopted rules that will be passed around, and each board member will need to sign those, so be sure to pass it to your neighbor when you are done signing. That will turn to the rules for adoption. All of the rules for adoption were proposed at the August 6, 2019 board meeting and were published in the September 27, 2019 edition of the Texas Register. And our first is a grouping of amendments concerning military spouses licensed to register in similar jurisdictions. And the first one is 283.12, and this came out of Senate Bill 1200. And on line 170, these amendments allow for an interim pharmacist license for a military spouse who is currently licensed in good standing in a jurisdiction with licensing requirements substantially similar to Texas's licensing requirements. It requires the military spouse to provide documentation, including a form that staff will create, proof of military spouse's residency in this state, a copy of their military identification card, and verification from their licensing jurisdiction. The interim license is only valid while the military service member is stationed here, not to exceed 3 years, and the interim license may not be renewed. And the next one in that grouping is 297.10, and this also comes out of Senate Bill 1200. And you can see the amendments on line 130, and these amendments provide for an interim pharmacy technician registration for military spouses. The requirements and limitations are essentially identical to the rule for interim pharmacist licenses. And there are also some grammatical corrections throughout. And that is the end of that grouping.
Any discussion or questions from the board members on this grouping rules? And if not, can we get a motion to accept?
Motion.
Motion came from Brad, second from Chip. All those in favor?
Aye.
Any opposed? The motion passes.
Next we have 291-121 concerning telepharmacy system in a federally qualified health center. And this came out of Senate Bill 670. And these amendments allow telepharmacy services in federally qualified health centers. Line 500, the amendments add federally qualified health center to the list of facilities in the definition of a remote healthcare site. On line 521, it provides that a federally qualified health center may be located in a community in which a Class A or Class C pharmacy is located. And we did receive comments from Cardinal Health in support of the amendments.
Any questions or comments? And if not, can we have a motion to accept? Donnie,
Second.
motion. Rick, seconds. All those in favor?
Aye.
Any opposed? Motion passes.
Next, we have a group of amendments concerning continuing education. And the first one is 295.8, and this comes out of House Bill 2059, House Bill 2174, and House Bill 3285. On line 109, requirement for 1 hour continuing education related to opioid use has been removed because this topic will be covered in the new CE requirements. On line 104 is the new language. First is a requirement for 1 hour of CE on pain management annually for a total of 2 hours each renewal, which came from House Bill 3285. This requirement would apply for renewals received after August 31st, 2021 and before September 1st, 2023. On line 111 is a requirement for 2 hours of CE on prescribing and monitoring controlled substances, which came from House Bill 2174. The hours must be completed prior to September 1st, 2021, and recorded on the pharmacist's next renewal after that date. And on line 118 is a requirement for completion of a human trafficking prevention course, which came from House Bill 2059. And this requirement would apply for renewals received after August 31st, 2020, and before September 1st, 2022.
Can we do the technician?
Yes. And then we also have 297.8, which comes out of House Bill 2059. And on line 72, there's a requirement for the completion of a human trafficking prevention course. And this requirement would apply for renewals received after August 31st, 2020, and before September 1st, 2022. And there are also grammatical corrections throughout.
Any questions or comments? I'm not sure where our feedback's coming from. Questions or comments on both the pharmacist and the technician? I think the one big thing is when you read through it and as, you know, it's communicated through, is it's one every year, not two together, so we've got to make sure that that's well understood.
These courses all exist.
There are courses that are out there, so we'll be able to make sure that any other questions or comments?
we have 295.13 concerning physician delegation in federally qualified health center. And this came out of House Bill 2425 on lines 110 and 112. It adds federally qualified health centers to the facilities in which physician delegation to a pharmacist may occur.
Any questions or comments? Can we have a motion? Donnie has made the motion and Jenny has seconded. All those in favor? Any opposition? Motion passes.
Next, we have 309.5 concerning communication with prescriber. And this came out of House Bill 1264. And this removes the expiration of the required communication to the prescriber regarding the specific biological product that was dispensed. We received a comment from Mary Staples with the National Association of Chain Drugstores suggesting that that language be added saying that entry into the electronic record system is presumed to provide notice to the prescribers. The suggested addition would go beyond what the statute allows. This language was not added to section 562.0051 of the Pharmacy Act. There is also a concern with third-party adjudication and the notice not being in the record that the doctor can access. This would be contrary to the law. The specific provision says the pharmacist reasonably concludes it is electronically accessible by the prescribing practitioner, so it can't just be in the electronic record system.
Any discussion or questions here? We can have a motion of acceptance.
No, could I ask a quick question on this?
Sure.
Just want to make sure we understand this correctly on the communication for the medical record system. That's sufficient notification, or was that what they were saying here? The communication that is conveyed, is that in the, as it says here, the DMR system, that's sufficient notification? Or what was the phrasing you said, it goes beyond what was law? Rule?
It would just need to be that, the way the law is worded, if you look at page 8 of the PDF, the highlighted portion is not in the law, but if you look at the language that's directly above that in B, it indicates that the communication may be conveyed by making an entry into the medical record or the electronic prescribing technology or the pharmacy benefit management system or pharmacy record that the pharmacist reasonably concludes is electronically accessible to the practitioner. So that's the part that, it has to have that caveat that the pharmacist has to conclude that it's reasonably available. But if the entry into the electronic record system does provide access to the physician and the pharmacist knows that the physician is aware of that, then it actually probably covers that.
Does that answer your question, Rick?
I assume so. I think the issue is just the assumption that it's the notification is proper, was what I was saying. That was my concern, was that it was not, maybe that assumption is going to be taken incorrectly by some pharmacists. That was just my concern.
That's why we didn't add it. Exactly.
Okay.
Any other questions or concerns? We have a motion for acceptance. Chip has made the motion to accept. Second from Jenny. All those in favor? Any in opposition? Motion carries.
Okay, next we have 315.3 concerning opioid prescriptions for acute pain. And this came out of House Bill 2174. On line 82, an opioid prescription for the treatment of acute pain may not be in the amount that exceeds 10-day supply and cannot provide for a refill with the exception of the treatment of substance addiction. On lines 53 and 73 is language clarifying the 10-day supply of opioids limit as an exception to those subsections. And there are also grammatical corrections throughout.
Any questions or comments here? We can have a motion motion for acceptance? Jenny?
Second.
Rick seconds. All those in favor? Any in opposition? Motion carries.
That was Rick Fernandez.
Yes, Rick Nance, oh, that's right.
I was just gonna say we might want to actually
That
know which
is correct.
Rick, since we have two now.
Next, we have 315.6 concerning zero reporting to the prescription monitoring program. And this came out of House Bill 2847. On line 64 is a zero reporting requirement to the PMP. If a pharmacy does not dispense any controlled substance prescriptions, the pharmacy must submit a zero report every 7 days. If the pharmacy begins dispensing controlled substances, the pharmacy must report per usual. On line 69, a pharmacy that does not dispense controlled substances may request a waiver by submitting a form and the requested information. If the pharmacy subsequently begins dispensing controlled substances, the waiver becomes invalid and the pharmacy must report per usual.
Do we already have one?
We do have,
Okay.
yes, but you have to request it. It's not currently not posted on the website.
Okay. Any questions or concerns with this? We can have a motion. Motion for acceptance from Lori. Any second from Brad. All in favor? Any in opposition? Motion passes.
Next, we have 315.11 concerning delegate access to prescription monitoring program data. And this came out of House Bill 2847. On line 49, these amendments provide that the PMP lookup may be delegated to a pharmacist intern or pharmacy technician trainee in addition to a pharmacy technician. It also removes the effective date from the title.
Any comments or questions here? We can have a motion for acceptance. Rick Fernandez, and a second. All those in favor? Any in opposition? Motion carries.
Next, we have 315.15 concerning prescription monitoring program access requirements. And this came out of Senate Bill 1564 and House Bill 3284. And on line 49, it changes the mandatory PMP lookup date to March 1st, 2020. On line 59, adds patients with a clearly noted diagnosis of sickle cell disease to the list of exemptions from required PMP lookup.
Any comments or questions? We can have a motion for acceptance. Chip, and then a second by Donnie. All those in favor? Any in opposition? Motion carries.
Next, we have the rules that are up for proposal. And the first is a grouping of amendments concerning removal of student loan default as a ground for discipline. And the first one we have is 281.7 concerning pharmacists. And this came out of Senate Bill 37. On line 133, it removes failure to repay a student loan as a ground for discipline of a pharmacist license. And then we have 281.9 concerning pharmacy technician and pharmacy technician trainees. And this also came out of Senate Bill 37. And on line 26, it removes failure to repay a student loan as a ground for discipline of a pharmacy technician registration.
All right, do we have any questions or comments regarding this?
I have a question.
Go ahead.
Have we had many cases where pharmacists are defaulted that we've had to know?
Because we usually are able to work that out, figure out the review, we have gotten that far, maybe.
Yeah, no, we haven't, because we are usually able to work that out. There's another state agency that, works with them to get on it, to make those payments. Same with the child support, so.
They notify us when they are defaulting,
Right.
and then we let them know we can't renew them, and then they start getting stricken out. So it's only happened like once, or,
Yeah, and maybe two times in the last 20 years that we've had an issue with it.
have 28166 concerning removal of arrest as consideration for licensure or registration. And this came out of Senate Bill 1217, which requires that arrests not be considered for licensure or registration. So in line 34, we've simplified the language to just say criminal history record to make sure that those arrests are taken out.
Any questions, comments? You have a motion to propose?
I do have a question. Kirsten, tell me, of course, if you erase the including arrest and all of that, how does that, the criminal record history impact just basic, we don't have them described, but how does that actually work?
We have a pretty detailed matrix of, the impact on your license that's contained in 281.64.
Okay,
And so that would outline what the penalties are, the sanctions that the board proposes based on each type of criminal, either conviction or deferred adjudication. We didn't really need this language in here because it's repeated in other places
Okay.
and it's obviously the law also,
Right.
that you have statutory authority for it. But we definitely wanted to remove the consideration of the arrests.
right, okay, thank you.
Any other questions, concerns? Do we have a motion to propose?
I'll make a motion.
Bonnie has made the motion to propose. A second? Second by Jenny. All those in favor? Any opposed? Motion carries forward.
Okay, next we have 28169 concerning automatic denial of revocation for certain criminal offenses. And this came out of House Bill 1899, and this is a new rule. And it states the board shall automatically deny an application for a pharmacist licensure or revoke a pharmacist license immediately upon notification that the person is required to register as a sex offender, has been convicted of or received deferred adjudication for a felony involving the use of threat of force, or has been convicted of or received deferred adjudication for sexual assault, aggravated sexual assault, or injury to a child, elderly individual, or disabled individual, committed when the person was providing services as a licensed healthcare professional and the victim was the patient. And starting on line 26, the person may reapply or apply for reinstatement if the conviction or deferred adjudication is reversed, set aside, vacated on appeal, or after the expiration of the requirement to register as a sex offender.
Any questions or comments?
Sorry, would that also apply if they successfully complete? So if they're doing it deferred and then? once they finish it?
No, it's only if it's, reversed, set aside, or vacated on appeal.
So if they enter into a plea agreement to have it dismissed, or dismissed, then
Yeah, I don't think we were considering it that way. Because of the fact that our statute allows us to have it deferred.
Any other questions? We can have a motion for proposal. Do you have another, look like you have another question?
that list of offenses, were those mandated in the law?
Totally from the law, we didn't make up any language here. This is all from the
Some
law.
experience with some of these charges,
Mhm.
and some of them aren't always what they sound like, so.
I mean, we already have the provision for revocation or denial of license or registration if anybody who's registered as a sex offender, so it really only adds,
But it's adding all the assaultive force, threats of force, it's,
if they're registered as a sex
Injury or
offender,
termination.
and it's during the time that they were patients. So the chances of that for a pharmacist are extremely rare. We've never seen that where it's been like the patient that was attacked. We see it, you see what I'm saying?
okay, I got you.
I mean, this was not just targeted towards pharmacists, this was generally towards healthcare providers, most of which have a lot more direct patient contact to their
I
patients.
missed the part about patients,
Yeah.
totally on.
Okay. All right, if we can have a motion for proposal. Chip's gonna make her motion for proposal, second, Donnie. All those in favor of moving forward? Any in opposition? Motion carries.
Next, we have 28170 concerning surety bonds for certain investigations. And this came out of House Bill 3496, and it is also a new rule. And a surety bond may be required for an investigation of a pharmacy involving 565.002A7 of the Pharmacy Act, which is failure to engage in or cease business, or 10, which is engaged in fraud, deceit, or misrepresentation in operating a pharmacy or in applying for a license.
Any questions or concerns here? If we can have a motion to propose.
Move to propose. Easy.
Rick Fernandez has made a motion, second by Donnie. All those in favor moving forward? Any in opposition? Motion carries.
Next, we have a group of amendments concerning sworn disclosure statement. The first is 291.4, and this came out of House Bill 3496, and it is a new rule. Starting on line 15, to qualify for a pharmacy license, a sworn disclosure statement form must be submitted unless the pharmacy is operated by a publicly traded company, is wholly owned by a retail grocery store chain, or is a Class B or Class C. For clarity, on line 8, a definition of publicly traded company is added. On line 12, there's a definition of retail grocery store chain. On line 22, it explains that the form must be notarized and must include any information requested on the form, including the name of each person who has any financial investment in the pharmacy, the amount or percentage of the financial investment, and the names of the other people connected to the pharmacy who may not have a financial investment. Next, we have 291.1. And on line 7, it requires the sworn disclosure statement for a pharmacy license application, and it also corrects a grammatical error. Then we have 291.3, and on line 47, it requires an updated sworn disclosure statement for change of managing officers, and on line 64 for change of ownership, and it also corrects grammatical errors. And then we have 291.14. And on line 17, it requires a sworn disclosure statement for pharmacy license renewal, and it also corrects a grammatical error. And that is the end of that grouping.
All right. Any questions or concerns with this grouping?
Did we not collect that information before?
We collected some information, but, no, this was, in order to make sure that we get all of the information prior to the issuance of the license or on the.
Any other questions or concerns? You look like you had one, something. No? We can have a motion for the proposal. Rick Fernandez. We have a second by Donna. All those in favor? Any in opposition? Motion carries forward.
Next, we have 291.34 concerning electronic controlled substance prescriptions. And on line 165, we're removing a reference to the Department of Public Safety because it doesn't belong there. And then we're also making some grammatical corrections.
Any questions or comments here? We can have a motion for proposal. Have a motion from Donna and a second from Brad. All those in favor? Any in opposition? Motion carries forward.
Okay. Next, we have 295.9 concerning reactivation of pharmacist license continuing education requirements. And to make this better match the pharmacist renewal requirements that were just adopted, we're removing the 1 hour of opioid abuse requirement and replacing it with 1 hour of the pain management requirement from section 41.0764 of the Texas Controlled Substances Act.
Any questions or comments here? We can have a proposal.
Wouldn't they also, do they also need the human trafficking?
That's only for licensees, so they would have to get that during their first year of being reinstated. Yeah.
So I think that is to get reinstated.
To get reinstated.
Not to do it.
Any other questions or comments? We got a motion for proposal. Donnie moves, Rick Fernandez seconds, all in favor?
Aye.
Any in opposition? Motion carries forward.
Next, we have 29513 concerning physician delegation to pharmacist under written protocol. And this came out of Senate Bill 1056. And you'll see the green highlights in there are what was just adopted. And then on line 63, it allows delegation under a protocol of implementation or modification of a patient's drug therapy if the delegation follows a diagnosis, initial patient assessment, and drug therapy order by the physician, and the pharmacist maintains a copy of the protocol for at least 7 years after the expiration.
Any questions or comments here? We have a motion for proposal.
Motion.
Rick Fernandez has made our motion, second. Donnie has made our second. All those in favor?
Aye.
Any in opposition? Motion carries forward.
Next, we have 315.3 concerning controlled substance safe disposal notice. And this came out of House Bill 2174. And again, there are some green highlights in there that are showing what was just adopted. On line 27, a person dispensing a Schedule II controlled substance must provide written notice on the safe disposal of controlled substances. The notice must include information on safe disposal locations, which can be a board-specified website that has a searchable database of safe disposal locations. The notice can be provided electronically if the patient or patient's agent requests it, and the request is documented. The notice is not required if the prescription is dispensed at a location that is authorized for safe disposal and regularly accepts drugs for safe disposal, or if the dispenser provides the patient with a mail-in pouch for surrendering unused controlled substances or chemicals to render the unused drugs unusable at no cost to the patient.
Questions or comments here?
Do we already have a website?
The website exists.
Yeah, the website, VA components.
And, I think we put it on our website.
Any other questions or comments?
Julie,
Yes.
my question is, if the pharmacy is providing the disposal bag, what do you call it?
This was our,
You don't have to provide written notice?
it's called, at no charge.
Or, okay. Do you have to publicize that you offer that somewhere, or you just do it as requested?
Well, then it needs to
It can be there.
be there.
Correct.
Yeah.
You don't have to put a notice up saying we have this if you want it.
No, there's absolutely nothing stopping you.
You can do that.
Yeah.
And clarification, it's not if requested, it would go to every controlled
Right.
substance, it would have to be automatic with them.
Unless you did have the written statement and all of that, then you could have kind of a combination of the two.
So are we saying that with every controlled drug, a form or a piece of information sheet is provided with the prescription, is that what this is telling us?
Correct. Or on the information that you already provide.
It's with C2.
Yes.
Mhm.
Well, I work at, at a cancer chemo retail place sometimes, and we have a lot of issues with medications that are dispensed, and the patient passes away, and then we're dealing with this, so.
Any other questions?
Can I ask some more clarification on what you had said? If we are not notifying the public that we have a disposal, we have to just automatically give it.
That's correct.
Okay, Okay, so if you don't notify, then go ahead, if you are asking and requesting, then you have to have that notice.
That's correct.
Otherwise, we have to default to the website as it is.
With the notice that they go there.
There's, 3 choices. You have the kiosk that people just put their stuff in. You put a notice on the written information that says, go to this website, and then they can find out where places are around them. Or you provide at no charge the packets to, get rid of it.
But you can still use a combination of those
Right.
if you want. You don't
Right.
have to have one.
You could have, well, you could have the kiosk, you could have the written notice, and you could ask people if they wanted the automatic disintegrator or whatever it is. Yeah,
And just to clarify, this is for C2s only, is that correct?
right, it says the Schedule II controlled substance, when you dispense that, it needs to be like.
Any other questions, comments, concerns? If not, we have a motion to propose. Chip has made the motion to propose, a second. Donnie has made the second. All those in favor? Any objection? Motion carries forward.
Next, we have 315.16 concerning patient access to the prescription monitoring program information. And this came out of House Bill 3284, and it is a new rule. And it says a patient or the patient's legal guardian may obtain a copy of the patient's prescription record, including a list of persons who have accessed the record, by submitting a notarized request form with any information or supporting documentation requested on the form, a copy of the requester's driver's license or state-issued identity card issued by the state's Department of Motor Vehicles. If the requester is a parent or legal guardian, a copy of the patient's birth certificate or order of guardianship, and a $50 fee. The board will deliver the records to the requester by certified mail to the address listed on the driver's license or state photo identity card.
Questions or comments here? Yes, sir.
So anyone who's accessed the record, we're gonna give their name as well?
We are going to only include the practitioners that have access to the record.
Not the delegated.
No, that would be included, but not law enforcement and DEA and investigators that are investigating them, because that would disclose confidential information.
Just kind of a little concerned that you got a technician who accesses the record to make an update, and their name winds up getting sent out to some random person, and you've got this, well, why did this person
That's the law.
access my record?
And they should only be accessing if it's their patient, so it shouldn't be a problem. But they look
Well, I
them up.
understand, but, you know, a patient's gonna come, I wanna see my records in that wire, depending upon their history, I've got 27 people that looked at my record at some point, why, and they're,
You're correct.
Right,
I see this as causing problems.
that's what the law is.
It would be in conjunction with filling the prescription, it has to be the course of normal duty.
Yeah, I will tell you that it doesn't matter whether we pass this rule or not, this is the law, and we're not still doing it. We just need to make sure that we have a form, and that's why we wanted to have the rule, because we wanted to have
Do we
set
get
of
requests today?
guidelines.
Do we get requests today for this type of information?
Yes, but we obviously are not honoring them yet. We did start the law enforcement access portal, and that's been working well, but, we are not responding to these yet, because we don't have this procedure set for it in terms of how we are going to allow the information to be released. We wanna make sure it's that person that's requesting the information.
And the law said that the board is required to adopt rules to put these
Put
things
that
forward,
part.
like the fee and the form and all that.
So is it just the patient, the person's name, or is there more information, like you access the record?
I don't think there's any more information than that.
So if a pharmacist looked up a patient and that patient then wanted their records, they would see whatever information was with the prescriptions they had, and then they would see that pharmacist's name, or the doctor's name, or the prescriber's delegate. They may have what they are, like if it was a pharmacist, or if it was a doctor, dentist, whoever looked them up. It's just the pharmacist's name. You would not know it was at a particular pharmacy. You would have to kind of figure that out as a patient.
The logins for the prescription monitoring program are not tied to a pharmacy. They're only tied to your pharmacist license. So it would just provide that information for the any delegates, like you're saying.
Does the law preclude us from adding the pharmacy to the released information?
There's no way to do that because
It's not set up.
it's not, the computer system's not set up that way. There is no tie to the pharmacy with the pharmacist in the computer system.
It's the pharmacist that creates the login and the lookup in the PDB, not the pharmacy.
And they could be working at numerous locations, and so they, they have one login, and we have no idea, if they worked at one place on Monday and someplace different on Tuesday, we don't know that in the system, in the PDB system, what pharmacy they're looking at that for, that they're working at.
Well, how does that work if you go to pharmacy A and patient is there and you're looking that patient up, and then you go to pharmacy B, that patient is not a patient of pharmacy B. That patient is pharmacy, they're not saying, they don't belong to that pharmacy. And we said earlier that you can only look up what you're a patient of the pharmacy you're going to. So, to me, I think it's a little confusing, but maybe it's.
So if I was working at pharmacy A and I looked the patient up,
And that was your patient.
and out, right, so I looked them up and they were my patient and I did or did not dispense the prescription to them. That's exactly right. And if I quit working at pharmacy A, is that what you mean, or? And now I'm at pharmacy B, I did that when I was at pharmacy A and that was okay. I'm not gonna look that patient up today at pharmacy B unless that patient comes in to pharmacy B.
Because it's not a patient of the pharmacy,
Yeah.
it's a patient of the pharmacist. And so it ties to the pharmacist. Obviously, the pharmacist can only do it if they're authorized to do it. And working at a pharmacy and dispensing prescription is one of those circumstances. But they wouldn't even have to be working at a particular pharmacy. They're doing drug therapy management or something like that.
Right. Okay.
And this record goes back to day 0.
Well, we only have 3 years of records in our system. That's how much we are allowed to keep, and that would be what the patients would have access to.
And that's a rolling 3 year.
It's a rolling 3 years.
So if a request were done today, if the rule was in place today, they could only go back to 2016, whatever today is, November 5th or whatever, for 2016.
Outside of this, possibly a new discussion, do we have a method for people to have inaccurate entry removed?
We do that all the time, we deal with having corrections made, definitely. The pharmacy has, again, now this goes back to the pharmacy, because it's the pharmacy that does the reporting, not the pharmacist, it's whoever dispenses the drug. And so the pharmacy has the ability to go into the system and make corrections. They actually have to do that within 7 days, so. But if there's something that's identified later, then yes, the pharmacy can make the correction, or we can make the correction if we get evidence that substantiates that that correction needs to be made.
Right.
And
Yeah.
the patient could also request it.
They'd have to provide us with, yeah.
So if someone requested their information and they said, hey, I'm John Smith and that's not me, they must have pulled the wrong one, because there was a bunch of them that were at the pharmacy, then what we usually tell people is, well, you need to go back to the pharmacy and they can make the correction. We try to get the pharmacy to just do the correction, but if they refuse, you know, then we would intervene on, you know, to get it corrected if we had evidence that it was incorrect. But,
Yeah, we do that now.
yeah, we do that now, when there's information that, the system looks for certain things, and it will, if the data's missing, it will throw out, and the pharmacies correct those errors. But then if there is like a mixed up patient, the system's not gonna know that, or a mixed up doctor. We would instruct them to correct it, and hopefully the pharmacy would do that. But if they don't, then we will.
Hey, I have a question for Rick. In a chain store, how does that work if a patient doesn't pick up a prescription for hydrocodone, and you've already processed it through the system? And how do you,
It'll get reversed, I mean, the
and then
the
does
hookups
it
are still.
automatically reverse off of that?
They have to reverse it.
They will reverse it. And that's done behind the scenes.
What was
That's
that?
done behind the scenes prior to the handle that process for us.
Okay.
I have a question. If a patient then obtains, or the guardian obtains this information, is there any protection on that data if they release it to the public?
Not according to our participation in that.
We wouldn't release it.
No, we
But
would
No,
not.
no, no,
If the
the guardian
person,
then turns around and releases it to the public.
that's,
No.
It's the same as any other medical record.
if
Right.
I
Well, I'm
release
just
my
saying-
daughter's records out there, that would be my, you know, when she's my child and I release them.
Right,
But
I was just,
there's
with
nothing-
PHI, Protection Health Information Act.
Sure.
I was wondering if there's any violation.
That would be on the parent that released it.
Okay.
But there's not any like HIPAA violation that's involved there because they're not a covered entity. It's only the covered entity that would be subject to that.
Any other questions or comments? If we can have a motion for proposal, Chip has made a motion for proposal, Donnie has seconded, all those in favor? Yes, sir. Any in opposition? Motion carries forward. All right, so next we have, our rule review.
So behind the tab C.3 is our rule review plan. State law requires you to review the rules on a 4-year cycle, and you're looking to see if you still need these rules. It is not about the content of the rules. And this time, our rules are up for proposal. And the first one is chapter 291 concerning community pharmacy, class A. And then we also have chapter 283 concerning licensing requirements for pharmacists. And chapter 315 concerning controlled substances.
Any question, concern that we need these rules? If we can have a motion. Lori has made our motion, Suzette has made a second, all those in favor? Any in opposition? This move passes. All right. Do we take a break? How about we take, clock is not right, because the time change, how about we take a 15-minute break? Come back at 10 after the hour?
Check 1, 2. Checking 1, 2, 2, 2, 1, 2, 1, 2. Check 2, 2.
How you doing? Thank you. Good morning. On our list, we have document 1.1. It shows the big picture of the summary budget for fiscal year 2019. And the next page shows a more detail by expense type and group of the budget for fiscal year 2019.
That's for the, finishing up our last fiscal year, and we actually had 92% of our budget spent. So, very good that we did not go over. We have a good, accounting department to make sure that we keep in line with all of our spending.
And give this response to staff.
That's correct, but all the numbers are in black. Our next on the list is D 1.2, is the budget for the board members for fiscal year 2019. You notice at the top that most of our expenses are at the duty point, which is Austin. But we also, you may have on your agenda to go out of state or in state. Some of the requirements might change based on travel policy. For example, lodging and per diems. And our last one is D 1.3. This shows our most recent major contract extensions between 3 of our suppliers. You can see the amount changes and the end dates for the contracts. Do you have any questions on any of these documents?
And for the board member travel, we'll update that. This was again for fiscal year 2019, so the new board members will be put into the FY 2020 travel budget. We don't have a lot of funds for traveling. We have allotted what we estimate your travel to be for the board meetings and informal conferences. That's that first block. For the out-of-state travel, we usually limit that to the board president. But if you do go out-of-state to a conference, if you submit that, we'll usually hold that to the end of the year. And then if we have the funds, we will then be able to reimburse you for that. And there's a little bit for in-state as well. And or if you choose not to get reimbursed, that's an option as well that we always appreciate.
All right, these are just reports, so we need no motion. Thank you, Raul. And again, welcome to your position. Our next on the agenda is our strategic plan, which you can see under tab 3.3. We'll go ahead and turn over Allison for a little bit of discussion.
Right, so every other year we're required to do a strategic plan that we submit in June, and we like to start working on it. Last board meeting, we reviewed a timeline of what we'd be doing over the next several months. We don't have instructions yet. We do not get the instructions until sometime in the late spring is when they send us the instructions on what to do for the strategic plans, but we like to get started on that. So we sent out letters to various organizations that we've done in the past. I think you had that in your packet last time of who we were going to send those to. And we got responses from the organizations that you see there on the left-hand side in the bookmarks. You also see what the issues are that the board has identified as being things that you want to address. And so if you want to make any changes to those, these have, I think, been pretty much what you've been focusing on for a while, but if there are any changes that you want to make based on any of the comments that you received from the organizations, if there's something you'd like to add or subtract, we can do that. But these have been pretty well the issues that you've been focusing on. And you don't have to vote or anything, it's just more informational on this.
So currently, the issues that are identified is the opioid epidemic, monitoring increased use of technology, address the appropriate level of training and supervision of pharmacy techs, in order for pharmacists' ability to provide clinical services, and then the increased licensee compliance with laws and rules relating to practice pharmacy through educational licenses, or licensees. In here, again, we don't need a motion, but do you feel like this is in line with our strategic, is there things that you would like added or? Alright. We will leave that as it stands then. Alright, so, our next item of business is D.4. Yes.
So, the little material changes in the financial, do we have to approve the material changes contracts? On the financial update, we skipped over that part.
On the contracts,
Yeah.
Your extensions.
no.
That's
So,
just for- I couldn't-
they're just for
we actually-
information, yeah, it's just for information, I don't think you have to approve those or anything,
Okay,
you can if you'd like to.
Yeah,
They're,
You just need to be informed.
you just need to
The
be
board needs to
informed.
be informed.
And, I think we're gonna revise the way we've done the contract, or done this reporting to you to make it a little more understandable. So the first amount is what we've currently paid that contract, even though it may have been several years. And then the addition is what we are adding on to, so it's kind of confusing the way it's on there, but we're just required to tell you about it, so there you go.
Alright, so our last meeting, we had asked the staff to go and draft some documents or amendments, concerning ratios. Megan, you wanna start by just walking us through those?
there were actually, several items that we.
Oh, that's true,
we
you
looked
wanna
at,
go
and,
through the list
so-
first?
So, behind item D.41, you have, sort of the areas that you talked about, at your last meeting that you wanted to look at. So, those were removing the technician ratio, allowing techs to administer immunizations, allowing technicians to receive new prescriptions, doing oral transfers, and clarifying prescriptions with prescribers. And so we have been working on those proposals. We only have brought you at this meeting the technician ratio issue. And behind one of the tabs, I think it's the fourth one down, we did check with the medical board about the immunizations, and that is not something that we would be able to allow technicians to do. So we will not be proceeding with that one. Then behind the third one, you also have a letter that is from Senator Schwartner, Senator Nelson, Senator Colforst, Senator Campbell, and Senator Buckingham with regard to the ratios. And then there are quite a few other letters there as well that are included. And then in your additions folder, you have more letters that came in after we finally had to kind of put a cutoff as to when we were uploading onto the website. But you've got more additions in your folder that we've received. And then also we just received another letter from Representative Sheffield's office that was just came in this morning, so right before the board meeting. So those are some comments you received. Megan can go through the draft language that we put together with regard to ratios.
So first we have 283.5 concerning pharmacist intern duties. And on line 24, it removes the ratio when a pharmacist intern is performing technician duties. Then we have 291.32, and this would be for Class A pharmacies. In line 208 would remove that ratio. And then we have 291.53, which is Class B or nuclear pharmacies. In line 160 would remove the ratio. Then we have 291.129 for satellite pharmacies. In line 88 would remove the ratio. And then we have 291.153, and these are our Class G pharmacies. And line 147 would remove the ratio.
All right. I know we have a number of individuals that would like to speak, but I'd like to start out by just having the board discuss these changes, concerns, comments, and let's have a discussion and we'll open it up. So I'll throw it out to the group.
Julie, just back, real quickly, Allison, circle back on the immunization portion. That's not gonna something we talked about. We'll talk about, like, what would be a process if someone wanted to consider doing that? There's a different process to do that outside of, or like to adopt a rule for immunization by, trained technicians.
So allowing technicians to do it, we cannot do that.
Yeah.
Because
That would-
it's it's a law that's part of the Medical Practice Act. And so we had to check with them to see if we were interpreting it correctly to allow technicians. And they said no. So we can't do any rules for that. There would have to be a change to the law that would then specifically allow it.
That's what I'm saying, before I change the law.
Yes.
It's not something we can do.
Not something that we could do here, yes.
Correct.
Correct.
How long have these current ratios existed? Somebody can give me a little bit of history on what these ratios were.
I think about 2013 was when we changed to the 1 to 4 ratio.
What was it before that?
1 to 3.
1 to 3?
I think it was 1 to 2.
So it's been slowly.
It's been slowly working its way
creeping
up. Yes. And in hospitals, the law does not allow us to set a ratio in Class C pharmacies. There is no ratio there.
So with the movement from 1 to 3 to 1 to 4 back in 2013, what was did we have data that made us feel that that was safe and a necessary thing to do, or what was the rationale?
At the time, we had a tech task force, and the tech task force at that time actually recommended that we eliminate the ratio. And we came back with I guess a compromise is the best way to put it, or the board did at that point. And it came back up to 1 to 4. There are a number of states that do not have any ratios. If you look at 1 to 4, 1 to 3, 1 to 5, 1 to 8, they are arbitrary numbers. I think the one thing that it does do is, as you start looking at numbers, it's all based on, what the pharmacist feels they can do. It does allow flexibility if you've got to train somebody. If it's 1 to 4 and you need 4 pharmacists or 4 technicians for your volume of business, and you need to have somebody come in and train, you're gonna have to be understaffed to have that training, to conduct that training.
Have any of these states collected any data, all of these arbitrary ratios? Is there any data that indicates that if there's ever a ratio that is so broad that it's unsafe for the public?
I don't believe we've been made aware of them.
Julie? My question goes back to when it went from 1 to 3 to 1 to 4. I looked at the previous discussion and some of the letters that were submitted, and there was obviously a lot of concern over public health, which is what we're here to address. Have we had any reports of the public health being compromised by us going from, say, 1 to 3 to 1 to 4?
We have not. there hasn't been any issue that was related to that increase in the ratio that we've been made aware of, that caused additional issues or problems in the pharmacies. Of course, we haven't actually studied it, this would just be complaint driven.
Always the outsider. I mean, I kind of have some concerns. Just meeting before last, we had pharmacists in talking about working 16-hour days and multiple days in a row and not having breaks. We just figured out we can't pass off immunizations to a trainee, which means you've got pharmacists potentially in a position where they're managing more people. If they're doing immunizations, they're leaving that area and administering immunizations. So you've got however many technicians sort of unsupervised at that time. Kind of.
Well, if you look at, the retail pharmacy and, depending upon how your immunization room is set up, an immunization really does not take very long. But anything that they do, the pharmacist has to come back in and check. So if it's your staging thing, again, it goes back to the comfort level.
I would be more inclined to, if apparently someone, there's gotta be some people that are saying, hey, we would propose, right, to remove the restriction. I'd be more inclined to do kind of a tiered kind of thing, 1 to 4, but you know what, maybe it's 2 to 10, or it's 3 to 18. You have multiple pharmacists, then you could handle more people. I don't know if that makes it too complex.
Well, and not all retail pharmacies are made the same. There are chains, and then you have your compounding facilities. And so, with regard to, in my practice, a ratio, I would find it very difficult to manage and monitor what my techs are doing in the lab if there were more than, if there were an unlimited number of them, or, I would feel comfortable with 4 or 5 per pharmacist. Anything over that, you're really risking the chance of an error being made, an error not being caught. Especially if you add, you're looking at interns on top of that. It's a lot for one pharmacist to have to watch and keep up with. And then back to, I wanted to just, from our hospital people, the unlimited ratio in a hospital, and it's been a long time since I've worked hospital. So going off of my memory, when, you're filling the cart or a Pyxis system, that technician is doing that, there's always a pharmacist that checks that or another tech checks that. But then there's also, before that patient is administered that medication, there's another healthcare professional looking at that medicine, whether it be a nurse who's about to administer it or a physician, like you said in the case of anesthesia. There is another healthcare professional looking at that medicine before it ultimately goes to the end user. That doesn't exist in retail pharmacy. So that really is another concern for me, not having that extra added protection when you have that unlimited amount of technicians to pharmacists.
Jenny, in your compounding pharmacy, do you utilize tech check?
No,
Is there an opportunity?
there could be. But with the computer system, and our pharmacists are in there with them, making sure that everything is correct.
Where did you have a comment as far as? You look like you determined it there, sorry.
Julie,
Yes.
just a couple things as we look at this, I think tying together the fact, for example, the immunization portion that you mentioned, Chip, it's just another task that the pharmacist is going to have to juggle with living personnel. And so, when we talk about work conditions, I think just trying to give them flexibility to have technicians available when they delegate, they need to do so. They can make decisions based on who they want to employ or not. The reality is, it's not going to be 15 tests. Just just budgetary wise not gonna happen. I just think there's a flexibility of profit and not when needed. The pharmacists make a lot of healthcare decisions all the time, and this is a decision they can make easily based on their practice. And so, and the other thing too, I wanna look at evidence in states where the rules have been elevated in ratios. I mean, I'm not aware of any state going backwards and saying this is dangerous or a problem, where they've increased it. And there's been some states that had it for decades and not had a problem. For an example, where I work, we neighbor New Mexico. New Mexico went to no ratio, and we didn't notice one difference in anything in terms of staffing or practices. All it was like giving the flexibility to pharmacists when they needed to, and most of the time it's going to be the usual budgetary we have now. The thought process is to help the pharmacists do their job at a higher level and to remove the tasks that could be delegated out so they can spend more time with patients. That's really what it's about. It's not about trying to train them 10 techs or 20 or whatever it is. That's really where I think is the concept, and it's in 20-some states already, and I thought something worthwhile to talk about.
Yeah, I would agree with Rick. I think we're operating in several states that don't have ratios, and we're not seeing any issue in terms of patient safety. Again, it gets back to patient training and things that are put in place at each of our businesses, for example, that drive that proficiency. And to Rick's point, I think, there's space limitations to in a retail environment or in a different type of pharmacy that you're not going to have 20 people in there with one pharmacist. I think it does allow them some flexibility. It allows them more freedom to be able to do those additional checks in their process because they're not having to take a call, do a clarification, the immunization, all that's off the table. I think it allows them more opportunity to move around the pharmacy and be able to supervise their technicians because they're doing those other functions for them. So it allows that opportunity to expand their clinical consultations and those things that happen that are, we hear a lot of our pharmacists want to be able to go back to that practice more often in their day-to-day. So, I kind of echo what Rick was saying. There are several states that don't have ratios and honestly have not heard or seen anything. We have, a lot of data that we don't have too on a daily basis.
Yes, sir.
Due respect, but without a ratio, it could very well that some pharmacy chooses to have 15 or 20 techs back there. And the whole purpose of having a limit is because we're looking at it saying, it's the same reason that we have speed limits. Because at some point we say, you know what, beyond this, it's just not safe. And that is our job as a board, is to try and impose it, and yes, they may be arbitrary limits. But at some point, there has to be some sort of limit. Otherwise, you could have someone that says, you know what, I've got a better way because I'm gonna bring in technology, and I can have 50 people in a room and only one physician checking it because, oh, well, the technology is gonna take care of it. And that just, I see that as being a potential problem.
I appreciate that, Chip. That's a good point. I think if you look at it, the task that pharmacist has to do is still there, and you can't load people up with 15, 20 technology-wise. They can load up that kind of work on them. Number two, budgetary-wise, it's not affordable in the environment we're in today. That's a big reason why today we have the problems we do, is that we cannot afford to have techs like this coming out everywhere. It's just to assist the pharmacist, because today's environment, it's about patient outcomes. It's not about filling scripts. So patient outcomes is impacted when the pharmacists have more freedom to talk to the patients at their discretion, not have to do a task that someone could be trained to do. But I do understand that, there could be somebody that's there that does that, but they would obviously have to be held accountable for that. That's a discretion of the pharmacist that's working.
I mean, at some point though, it is budgetary. How many techs could you have for what you're paying a pharmacist? And that's really what it would come down to. If I did one pharmacist, how many techs can I put in there on that same day?
You can't go in and go over it today, and the budget won't allow it. I mean, this reality is, it's not, in other states where these are out there, you're not finding pharmacists or organizations that are putting in 10 techs or whatnot to, it's just not feasible budgetary wise, because the patients today can view us as a commodity that fills scripts, and that's not sustainable. Sustainable is about patient outcomes. Patient outcomes is driven by the pharmacist being available to answer questions, not to be worried about workflow. That's a transition we have to make someday. So, and my feeling is, it's not to try to reduce pharmacists at all, it's actually to help advance the profession forward, so that some of these tasks can be delegated when necessary, and not to have us be working the way we've always done before. We have to try to find ways, because today's economics don't allow us to have that many techs, but because of those economics, it's because of outcomes being the real reason why we have the job today, not because filling X number of scripts. That's really not, they're not sustainable. So I just think looking around at other states where this is there, these examples don't work there. And again, going back to when we went from 1 to 3 to 4 to 1, whatever it was, the same concerns were brought up back then about safety. Nothing happened. And then you look at any state that went from 4 to even a limited, no one's called and say, we better put it back the way it was because it's unsafe. That's just looking at the evidence, that's all.
You're saying nothing happened, but yes, our level of complaints has gone up. Is it related to the fact that you're overworking pharmacists and you have too many techs now? I mean, we haven't certainly done any studies, but you can't say nothing's happened because the number of complaints that have come in and the number of errors, that's continued to go up.
But those errors being,
and it's going to continue to go
but
up.
those errors been mitigated if they had more technical support.
Okay.
We don't know.
Yeah, so, I mean, there's no causal relationship there. I don't think we can make that assumption. You know, I would kind of reiterate a little bit of what Rick said as far as states that don't have ratios. You know, we operate in a lot of different states, and we have the exact same labor model in the state we're in now as well as those states. So the number of techs, whether or not the ratio is 4, 5, or unlimited, the staffing is exactly the same. We don't switch out pharmacists for techs. It's just not a viable option based upon the task that each must do.
And so in those other states, what's the functional ratios that they're running? Pharmacists to interns, pharmacies in other states, they're running, they can't have practically unlimited, but what is the viable ratio that they're running in other states where there is no legal limit?
So in our company, you know, I can't speak for others, in ours, it's based upon the number of prescriptions that are filled. So as you fill more scripts, you add more techs. At a certain point, that's where you add a third pharmacist, which would then create your overlap. So it's all based upon production, whether or not there is a ratio in one.
And I would echo the same, there's not a separate rule, ratio, labor, that's going to automatically switch to. It's just a flexibility when they have a peak time or additional tasks they want to get done, they can need someone to help them for a while, and if they don't want to do it, they don't do it. I mean, it's just based on labor, it's not changing any of the criteria that we've used already in other states, it's the same process.
I think Texas is a bit unique in that we are so large. Comparing Texas to the other larger states like California, Florida, they do not have an unlimited ratio. California, I believe, is 1 to 2. Florida is tiered up to 1 to 6. Compounding is 1 to 3.
But with California, for example, they don't classify technicians, they don't really do anything back there. They might have a 1-to-1 ratio, or 1-to-2 ratio, I think it's 1-to-1, but the cashiers can do anything. So they still have the same type of labor modeling that other states do, just that the ratio says 1-to-1, but they actually have different classification of support personnel working back there. It's not comparable in that sense.
Well, maybe that's what we need to address, is the tiered system and not just across the board go unlimited, because retail is not all created equal.
No, it's not. It's not, nothing is 100% comparable, but it doesn't mean we're an island unto ourselves either, that we're completely different. I think that there are pharmacies that are very busy in other parts of the country, very so just like here. And so it is transferable in terms of the type of work environment. Not completely the same because there are different rules here, potentially for states, but it's not in a complete different environment that we couldn't compare other states. But the thing is, the rules and regulations are different, in how people classify technicians in the states. That's I hear you.
We talked about multi-tiering pharmacy technicians. I mean, that's come up before, about having either an advanced licensing people, something like that, that has additional. I mean, I would feel better about increasing ratios if there was some way for us saying, and certainly no offense, but that a technician that really at this point studied on their own, went and passed a test, that you could hire a bunch of them, probably wouldn't want to, you're gonna want some experienced people, but I would feel better about increasing ratios if there was some sort of tiered licensing for technicians.
They're gonna have to be in school for education for them to be able to, so they have to create a program or something like that. I don't think there are programs out there.
And again, it's discretionary pharmacists. I mean, they're not rejected to every role, so you don't have, different levels of expertise and experience in these pharmacies. It doesn't mean that you hire everybody and they do everything. There is training and experience, and the pharmacist can make that discretionary call to operate the practice.
Okay, I think you had a comment before, did you have that one?
In a chain setting, is it the pharmacist that's making the hiring call, or is it?
Yes.
Is it a corporate? Okay.
Absolutely.
It's that person?
Mm-hmm. I don't know if anybody works not a pharmacist, and it's their, they're making the schedule, they then decide when they have them and when they don't. I mean, we have financial guide rails as far as, like I said, the production, when you hit this number, you hit this number of techs, or tech hours, again, my company, but, it is up to the pharmacists, they're the ones that have to supervise. And I know that there are states that have additional rules in there, that stipulate that the pharmacist has the right to, say, this is all I'm gonna do, or not. So
this is a little concerning to me because, we've opened all these pharmacy schools in Texas. I mean, I know in the last 3 years, we've got them in many of the cities in the state. Well, why, and I understand the financial impact of making money with all of our pharmacies. But if it does compromise the health and safety of our public, then why are we not focusing more on having another pharmacist in the pharmacy, not 8 techs and 1 pharmacist? I know it's a financial thing, but, if at our different issues we've seen with informal conferences, we've seen a lot of things that have occurred in pharmacies with, the pharmacist is doing immunization. A tech is filling a prescription, not being checked properly because the pharmacist is there by himself. And then the medication gets out, they're not properly counseled, then we have an issue, it gets worse, and then they end up with us. And pharmacist, and tech are all involved. And to me, it's because the pharmacist did not have the support he needed, or they needed, she needed. But anyway, I'm concerned about having a lot of techs and not as many pharmacists. But I do like the tier. Hospitals have one set, maybe mail order, and you work in mail order, so it might be a little different in your situation than actually retail when in a retail environment. But anyway, I'd like to know, Lori, is that how y'all handle? What is your thought on the hospital, because you kind of you're the lead on that?
Yeah, well, if I'm rolled by number of good ratios, like I said,
Right.
that's never, I think that it's been never under consideration. But as the pharmacist in charge of my organization, I fully recognize what has to happen to make sure our patients are safe and taken care of.
Right.
Really, if you were to sit here and do the math on what my ratios are on any day, it's going to be like a 1 to 2 ratio. Because I have so many pharmacists engaged in so many clinical activities. The technicians are doing
through the letters that they submitted a couple of weeks back. And it concerns me that while many organizations would continue to support the pharmacist and give them the autonomy and the decision-making that they need to be able to safely take care of their patient, that if we make the law too loose, that a less responsible organization may not do that and can do that outright. So that's really where I'm at. But in my world, the ratio discussion just isn't.
Well, and you know what's interesting, you have over 30 pharmacists working for you, right?
Yes.
And you have total of how many employees? So it's, do you see the ratio, and then she has the nurses and other clinical staff looking at everything before it's administered. So to me, that is an example of quality healthcare right there. And I'm in a hospital environment, but she has a lot of staff, you know, that can handle
But
it.
we're looking at one hospital. The reality is hospital pound ratio, so.
Correct, I'm just saying, if the hospital then has another layer of security after it leaves the pharmacy, then, you know,
Not to mention the hospital world, all of the technology that goes into it before it reaches the patient. When it's loaded into an automated sequencing scan, for barcode scan, when it's removed, it's barcode scan, prior to administering the patient, it's barcode scan. So, but it's, again, just a different world of discussion in the hospital, it's really tough.
It is kind of apples to oranges. I think the economics are not the same. It's very different. And it comes back to the root cause here. Pharmacy today is being evaluated as a commodity. It needs to be more patient outcomes. And the limit that, because of that, the pharmacy has to be more available to the patients than ever before. That's all I'm saying. So limiting some of the tasks that they have to go back and do and help them get support for it is what it's about. It's not about reducing pharmacists. It's not about loading a bunch of techs in there, and it's about having the pharmacist the flexibility to impact patients so that the profession is sustainable long term. The economics right now, did anybody read what's going on? The economics are not good in pharmacy right now. And part of it is the pharmacist is not spending enough time impacting patients. That's all I think this ratio discussion is about. And in looking at other states where they have expanded roles and hasn't created a bunch of issues with care or violators and things like that. So that's really what I wanted to kind of end on.
All right, I think it's important to, you know, while economics may come into the conversation, it really is not part of our consideration.
It's not, but if the economics impact the ability to have pharmacies available for patients, that's all I'm saying.
It is about accessibility.
It's about having accessibility.
All right, so we are gonna open it up for public discussion or comments. You know, I'll ask you to pay attention to the individuals that are speaking. Introduce yourself. I ask you to make your comments brief and not to repeat comments from other individuals that may have had the same thing. So if someone has your point of view and they've already spoken it, then let that stand.
Greetings from San Antonio. It is always an honor and such a wonderful privilege for pharmacists to be able to share with their state board things that happen on the front lines. My name is Jeff Carson. I own 2 retail hybrid pharmacies in San Antonio that do compounding, sterile and non-sterile. I also own a home infusion pharmacy and a closed-door nursing home pharmacy. I've been practicing for over 20 years. I'm a 3rd-generation pharmacist. And I do not envy the position that you guys have. This is a difficult decision to make. There are a lot of people that are influencing it in many different ways. Our Board of Pharmacy has historically set the standard in the country as being a quality decision-making body, and I respect you guys with just the utmost gratitude of the work that y'all put in. I'd like to just start with the reiteration of the mission of the Board of Pharmacy is to protect. I always thought as a young pharmacist it was there for me. It was there to help me be a good pharmacist, but it's really about protecting the public. And the reason I start with that is I have to ask the question as to why are we here discussing increasing the ratio? Is it about improving the quality of patient care? Is it about increasing the safety of the public? Because that is the charge of the State Board of Pharmacy. Historically, as it was just referenced, the State Board does not take in consideration the financial viability unless it has to do with decreasing access to care. We must maintain access to pharmacists for our patients. That is a necessity for quality health care. But then again, what is the reason that we're asking for an increase in the ratio, or in this case, an abolishment of the ratio? And I think that's something that needs to be discussed. Is it because we need pharmacists to do more? We do need pharmacists to do more, but there's a challenge with pharmacists doing more right now. We're not getting paid to do more. So if you want to have the argument that it is a financial one that we don't historically make, then the argument must be had that until pharmacists have a viable business model to get paid to do clinical services, then all we're doing is replacing the pharmacist with lower cost employees with no life raft to float on, no business model to make the practice of pharmacy sustainable to the extent that we can do the more that we all know and want to do. So you can have the technicians dispense all the meds, and we can go out and talk to patients until we're blue in the face and sell them a bottle of Tylenol, but we're not getting paid a reasonable return on investment to do those other things. And I think that's important to comprehend and understand. I think the camp or the argument right now is free the pharmacist up so we can go do these other things and increase care. But if you can't make a profit doing that, there won't be any pharmacist to do the other. It has to be a viable model. I think the more responsible approach is let's seek out ways, and this is for the private sector, to find a financially viable model for pharmacists to migrate to before we increase the lower cost labor to replace the current job that is the pharmacist. So I get back to what is the real reason that we're here and talking about the ratio, if it's not about increasing patient quality or patient safety. And I think it really is just a simple, people want more technicians, less pharmacist salary. To drive down the overhead, which as a business owner of 4 different pharmacies, I can tell you my number one expense is payroll. So I'm conflicted, because I sit here before you today with a struggling independent mom and pop pharmacy. It's been in my family for 2 generations. I would much rather pay lower cost salaries and have a bunch of technicians doing what my pharmacists are doing right now. But I'm also conflicted because first and foremost, I am a pharmacist, and I know that it's not the right ethical thing to do. So what are my concerns? Well, I start with something that Jenny articulated so eloquently. We are Texas. We are not Oklahoma, New Mexico, California. We aren't those other states. We are unique. And our charge as a State Board of Pharmacy is not to do what other states do. It's to do what's right for Texans. And that's it. But if you're curious, there are 22 states that have no ratio in the United States. There are 28 states that have defined ratios. Of those that neighbor us, Arkansas is a 1-to-3, Louisiana is a 1-to-3, Oklahoma is a 1-to-2. But we don't do what other states do. That's not what Texas does. I'll tell you, I do all the hiring in my institution. I have 53 employees. I can tell you in my years of practice, and for anybody who knows me, one of the first things I tell my pharmacy students, and I get right in their face that first day of rotation, I tell them a pharmacist is only as good as their technician. I have a tremendous amount of respect, and I love all my technicians because we could not do what we do today without them. So I have a lot of respect for that. But I'll also tell you on the flip side of that, there is a huge delta between the education and training that goes into being a pharmacist and that which goes into being a technician. If we want to push technicians into a more responsible role, we've got to fix the education side on technicians. There is a big problem with that, and I don't see that being addressed in today. As I hire technicians, the best technicians I have on my staff, I hired them because they were registered clerks, and they were articulate with patients, and then I trained them, and it takes years to make a good technician. It doesn't happen overnight. The associate degree programs lack any standards in training. And while there are great technicians out there, if you open the door now and abolish the ratio, the need for technicians will escalate exponentially, and there are not an exponentially available number of qualified technicians out there. What we saw with this pharmacy technician certification happening in the state of Texas, as well as the increase in the ratio, we saw an increase in the technician enforcement activity that I see in my state board newsletter. Drug diversion is a big topic today. If I'm in the room doing immunizations, and by the way, when we do immunizations, we do travel vaccines, I'm not in there just to stick a patient with a flu shot and walk out. I might be in there for 30 or 40 minutes with a patient because they're traveling to a foreign country on a mission trip. And I've got to administer 6, 7, 8 different vaccines. So yes, my technicians are unattended while I'm doing that. And that's discerning to me, especially when you have drug diversion running rampant in our country. The value of that bottle of hydrocodone far exceeds the salary that technician makes. And that temptation is all too great. There are also certain practice settings I can tell you that if we go across the board and blanket wipe out the ratio, we are putting patients at risk. As I mentioned, I'm a compounding pharmacist at heart. It's one of the things that we do really well. In the sterile compounding setting, in the retail setting, if you take away the ratio, you're gonna put people in harm's way. In the non-sterile world, the same thing exists. There's only so much a pharmacist can handle in their workload today, but stand in a room and be responsible for everything that's going on around him or her in a compounding lab. Especially when you're wanting us to do more when it comes to quality, right? More USP, more USP 800, all these enormous burdens on me, and now I have to manage more technicians just to make my business model work. I'm concerned about that, very concerned. I can't speak for the other practice settings, like nuclear and so forth. I can't speak for the hospital settings, but I can tell you in the retail world that is gonna be a big challenge. So a tiered effect of some type, I think is important. And technology was mentioned. There are some great businesses in this room that are represented, and they have extraordinary technology that probably allows them to support a higher ratio of technicians. I don't have that technology. I can't pay for it. My guess is that there are around 1,500 independents in the state of Texas that can't afford that kind of technology. So I think you must pay close attention to the different practice settings, and then within retail, there are different tiered settings that have the ability to handle it and some that do not.
Okay, we've got a lot of people that I know who speak, so.
Absolutely.
I wanna.
Let me close by saying this. If you were to blanketly remove the speed limit in the entire state of Texas right now, most of y'all will drive the right limit. You drive through that school zone, you'll drop down to 20 miles an hour because you've probably had kids or you know kids and you want to protect them. I'm not concerned about the most people. I'm concerned about the handful that won't pay attention. Because if you take the ratio, I've heard it said today, well, my institution will not increase technicians. There won't be 18 in a room with one pharmacist. Most people won't, but somebody will. In fact, there will be more than one person that will. We've seen it time and time again. Don't blanket take away the ratio. That's not a good idea. I think we need to think through this, and I think there needs to be a little bit more structure to the increase. We would support a structured increase, but I cannot support the abolishment of the ratio. Thank you for your time, and I appreciate y'all listening.
Thank you. Please introduce yourselves.
Hi, I'm Debbie Garza, CEO of the Texas Pharmacy Association. Is this on?
Oh, yeah.
Oh, there we go. Debbie Garza, CEO of the Texas Pharmacy Association. And with me is...
Yeah, I'm Ranan Chang. I'm the pharmacist in charge of Tarrytown Pharmacy and the speaker-elect of TPA as well.
So I already provided our comments to you, but I just want to highlight a few points. Granted, TPA represents all pharmacists practicing in all practice settings, right? And so definitely there's not unanimous agreement amongst everyone about our positions. So with that, our board, we did look at this very carefully, and we took a measured approach whereby suggesting a ratio of 1 pharmacist to 8 technicians with allowing that to give some flexibility for the pharmacists to utilize their professional decision-making, while at the same time allowing them to utilize their personnel as best they see fit. I think we recognize that still about 30% of pharmacists' time is spent on administrative duties. And if you think about the realities today that pharmacists face, and hearing from the different pharmacists in different settings with regards to the peak time, drive home time, first of the month, flu season, et cetera, you not only have those 4 technicians, but you also have, of course, your cashiers who cannot help you. And so you're harming patient safety, you're impacting patient safety whenever those pharmacists are getting pulled away with these distractions to take care of these administrative tasks. And so this ratio does not mean everybody has to go to 1:8. It means that it's professional judgment that can be determined in a community pharmacy based on what the needs are of the business, of their practice setting, based on the needs of the training of their technicians, and based on, many things that go into play with their volume as well as the services. We talk about services and wanting to also not only make sure your role is to protect the safety of patients, but it's also to promote and preserve as well as protect the public health and their welfare. And pharmacists are moving into more patient care services. When you think about many of the laws we passed this past legislative session, and some of the rules are all finalized today with regards to pharmacists doing more collaborative practice and pharmacists doing more services, being recognized as a provider on the medical side, we need to make sure that pharmacist is freed up. So when you look at today, the status quo is a powerful undertow. And as we look to move forward, we've got to recognize we can't come back here a year from now. We've got to allow pharmacists some flexibility. And that's the reason why we would urge you to look at a 1:8 that recognizes the situations we're in today with the cashiers, the clerks, as well as the technicians, as well as where we want to go now with this legislation that allows us to work in more team-based care with our physician partners and others, as well as being paid for services on the provider medical side of the equation. So thank you for your time and appreciate your consideration.
Yes, and thank you for having us speak as well. I appreciate all of you. I think there's a lot of debate and a lot of good discussion that was had, and we had the same kind of discussion as well. I think our proposal is a really good middle ground. We're able to give the flexibility as a springboard to kind of start looking into more staffing to have these clinical services. There's new laws in place where we can now start providing services and get paid by commercial health plans. And so to do that, I need staff to be able to and especially our technicians, because it's not a financially feasible option for our pharmacists to do that. And so my technicians are going to be a huge part of not just pushing the profession forward to, again, be able to fund more pharmacists to be there to take care of patients in the way that we need to. But also I understand as well that we want to make sure we guard against those few that would take advantage of the system. And so I think this is a really great middle ground between giving us enough springboard to move forward with the profession, but also making sure we take care of patient safety as well. Thank you.
And one quick question, just for clarification for the board.
Yes.
Terrytown is an independent pharmacy.
Yes, thank you. Yeah, Terrytown Pharmacy is independent here in Austin since 1941. Thank you.
Thank you. Good morning, President Spear, members of the board, and the board staff. My name is Sandra Geckian, and I'm here today to represent the National Association of Chain Drug Stores. I've also been a licensed Texas pharmacist for 30 years. I'm here to express support for the advancement of patient care by the removal of antiquated, unnecessary pharmacist to technician ratios. Healthcare providers, including pharmacists, face increasing pressure to deliver high-quality healthcare services to a greater number of patients. Use of technicians to perform administrative and non-judgmental, non-discretionary tasks are integral to maximizing the time that pharmacists can spend in direct patient care. It's critical that restrictive ratios be eliminated to allow the practicing pharmacists to evaluate their individual practice setting and determine appropriate staffing for their pharmacy that will meet the needs of the patients that they serve in their local communities. Pharmacists are healthcare professionals, and their primary focuses in their practice are patient care and safety. And like physicians and other healthcare providers, they should not be needlessly burdened by administrative tasks. Arbitrary ratios undermine the ability of community pharmacists to best manage the needs and the requirements of each individualized pharmacy to provide population-specific patient care. Set staffing ratios, in particular, prevent pharmacies from maximizing the use of technicians to provide a broader set of patient care services available to the public at large. For these reasons, NACDS urges the board to remove unwarranted ratio restrictions. Such action would be an important step to modernizing the practice of pharmacy in the state and aligns rules and regulations with the healthcare needs of today's patient population. And although our viewpoints may differ from some that have been expressed today, we do recognize and acknowledge those viewpoints regarding the elimination of the ratio. And we are willing to work towards a compromise, and for all the reasons stated above, and due to the increasing prescription volume and the changing practice of pharmacy to become more patient-centric, we would welcome a dialogue that would discuss other alternative proposals, such as increasing the ratio. So thank you very much, and I appreciate your time and your consideration.
Yeah, Chip, you had a question?
Obviously, you're way in tune with this much more than I am. Is it your position that the current limits are adversely affecting patient care?
No, we don't believe they're adversely impacting patient care, but if you look to the practice of pharmacy and you look at what is happening around the country and federally, and you look at the future external influences in pharmacy, we're going to need to position pharmacy to have flexibility to evolve the practice to meet all of the new requirements that will be put forth in terms of pharmacy quality metrics and all the things that are being discussed primarily at the federal level. I mean, we've discussed today the evolving model of the practice. We do understand it's not the purview of the board regarding the financial structure and viability of pharmacies, but all of these things do come into play. And so it is something that as we look to the practice evolving and being able to have Texas pharmacists meet future requirements, whether it be placed upon them by Medicaid or Medicare or even private commercial plans, that pharmacists have the flexibility to develop a practice model and utilize staff in a way that will, again, advance patient care.
Any other questions for Sandra? Thank you, Sandra. Your next speaker.
Hi, my name is David Lee, and I'm a pharmacist with Kroger. And as an active and practicing pharmacist, I agree with the NACDS request to revise the pharmacist to technician ratio in Class A pharmacies. And I'm here to share my experience with you on how the current ratio is affecting patient care. I was staffing in a pharmacy where I had 4 registered pharmacy technicians. A patient comes up to the register and says, "I'm here to pick up my prescriptions." My technician looks it up, says, "I'm sorry, ma'am, it's still not ready. Can you give me another 30 to 40 minutes? When I look up, I see that there is a plastic wristband on the patient, similar to what you see when a patient's admitted to the ER. And I said, "Don't worry, ma'am, we will get that for you as soon as we can. Can you please have a seat?" So when I look up to assess the situation to see what technicians I can delegate this to, my technician at data entry is on the phone with the doctor's office, and she also has a patient that's waiting in line. I look at the product dispensing technician, and he's also on the phone trying to handle insurance adjudication. My third technician is at the drive-thru, working a double drive-thru at the pharmacy, so she's busy. And so I go myself and I grab the hard copies. There are 3 prescriptions on there. I go and I type them up and I proceed to dispense them. I hear a technician shout out, "New prescription on line 1. And I said, okay. Then I continue to dispense the prescriptions, and then the technician at the register says, "I need a patient counsel." So that I do go and I address, and I counsel the patient. Come back to dispense the medication. And I typed up the prescription, I filled the prescription, and then I verified it all within a span of 10 to 12 minutes. Once I hand these 3 prescriptions to my technician, I said, "Can you please ring up this patient?" She said, "Yes, also, by the way, you have the couple over here needs their immunizations. And so I felt like I was pulled out of my pharmacist responsibilities and duties to work in workload in regards to data entry and product dispensing, which pharmacy technicians can do without the pharmacist's knowledge and training, and they're not really professionally rewarding for pharmacists, and to add further multitasking to the pharmacist, which creates stress and can provide, which gives me less time to provide care for patients. So with that, the removal of an arbitrary ratio limit in Class A pharmacies would free up pharmacists like myself to perform pharmacist functions that are beneficial to patients and alleviate some of the express workplace environment concerns without jeopardizing patient safety. And this is something that happens daily and multiple times throughout the day. And so again, I as a pharmacist agree with NACDS request to revise the pharmacist to technician ratio in Class A pharmacies. Thank you.
Thank you. Next speaker.
Good morning, my name is Brian Fagan and I'm a pharmacist with HEB. And I support a proposed rule change that would eliminate the pharmacist to technician ratio in Texas. I think that pharmacists should be able to decide how many technicians they are capable of safely supervising. Naturally, this decision would be based on their knowledge of their technicians' competencies and their business needs. My technician assessments are based on the accuracy of their work, their ability to perform all of their technical aspects of their job, their knowledge of their laws, their ability to provide patient-centered services, and the content of their character. My technicians are knowledgeable and trustworthy, which is extremely important because I know I can do so much more for my patients if I was allowed the flexibility to staff accordingly to my business needs during peak time of the day. Every day in my pharmacy, there are approximately 180 different tasks that need to be completed, but because of the 1-to-4 ratio, I'm not able to adequately staff my pharmacy to successfully complete all these tasks. So rather than spending time counseling, immunizing, verifying scripts, performing DURs, I'm forced to do things like run the cash register, take out the garbage, put up inventory, just to name a few. Based upon my experience, the number of technicians working in the pharmacy should be up to me and not some arbitrary ratio. There are times of the day and times of the year where you simply need more technicians, especially during the flu season. When I'm out doing shots, I'm getting pulled 6 different ways to answer the phones, giving shots and providing counseling. This simply makes filling a script just take longer. Ultimately, my goal is to offer the best customer service with the most knowledgeable folks in the safest manner possible. The intent of the ratio is to protect patients, presumably because pharmacists cannot be expected to safely supervise more than 4 technicians. This is ridiculous. The 1-to-4 ratio does not increase the effectiveness, efficiency, or safety of the filling process. Rather, it is the quality of the people who make up the pharmacy team who make that difference. Based on my experience, errors happen because you are understaffed, not overstaffed. And the errors that are made, they're not judgmental errors, they're just simply human errors. Ultimately, I will be responsible for the supervision of my technicians, no matter if there's 2, 5, or 10 technicians working. Opponents will state that the chains will utilize this measure to overstaff their pharmacy with technicians. This argument, however, does not make good business sense. Analyzing and implementing a good business plan based on staffing metrics, prescription volume, and a good pharmacy budget will help sort out the appropriate number of pharmacy staff. I'm confident that eliminating the 1-to-4 ratio is the right choice. My technicians are well trained, and we have the operating procedures that we've created. We have operating procedures that have created a system conducive to a safe and efficient filling process. Again, the pharmacist is the most capable of judging the competencies of their support staff and should be able to have that option and not be restrained by ratio requirements. Thank you.
Any questions for the speaker? Thank you all for your comments.
Thank you very much. So can I ask a quick question? For those of you who work in this setting every day, I appreciate hearing what that's like. It's very important to me. Do you all have the autonomy when you are so overworked that you need to bring on an additional pharmacist, since the ratios don't allow you to bring on an additional technician?
Yes, it's just based on the number of scripts we're filling. So, I mean, like, can I decide to call another pharmacist to come in? No. Those are already predetermined. So, year over year, our script volume, it increases 3% every year. So we're able to predict basically, okay, going into next December, we need another pharmacist.
Thank you.
Also to add to that, your question is if we can add another pharmacist. Ideally, yes, but I don't necessarily have to. Whenever I am being pulled into like a workflow like data entry and such as dispensing, I am not visually watching all my text as like I would be if I was in verification, just verifying prescriptions. I can hear things. I can hear the technician at the drive-through, and I can basically hear all around me. But when I'm focused on filling prescriptions and counting pills and typing and making sure everything's correct, that's when I do not have the ability to hear things around me and things that can get missed. So if you add another technician, that would help as well. And that is kind of the, kind of what we're talking about.
Thank you all.
My name is Daniel Nayakundi. I've been a pharmacy technician for 14 years. So I just want to, first of all, thank the board for what it's doing in terms of trying to address this problem. I was here 2 quarters or 3 quarters ago when the problem came up. I do believe pharmacists do need help, and I'm not going to dispute that fact. And I just want to pick on something that Chip said, which is, because I know as a board you're concerned about patient safety, and that's the paramount objective of the board. And to what Chip said about maybe having an advanced role probably will create a comfort level to everyone to at least have those limits increased if you know for sure that you have well-trained staff, whether it's having a mixture of advanced technicians with a mixture of just registered technicians. If that will then present an opportunity whereby a pharmacist is not focused on supervising just say 4 or 5 technicians, but we have some more mature, better trained technicians that can act independently by themselves. With minimal supervision, of course, we're always going to have a pharmacist. And I wonder if that creates a compromise whereby the board would be inclined to create this second tier of a technician role that has maybe more a need of accreditation or a need of more training, whether it's having a certain number of hours met for that technician to qualify as that into that subcategory. That's all I had to say.
Thank you. Our next speaker.
Hi, I'm Jim Hernser from Mullen.
Oh,
I'm Jim Hernser from Las Colinas Pharmacy. I'm looking around and I didn't realize, but I'm an elder statesman now. I got my pharmacy license in 1978. Jeez. So I've watched an evolution. It's been kind of fun to watch this evolve. And I can say attaboy to the Texas State Board of Pharmacy, because nationally, I've seen a lot of my buddies suffer under really unusual rules that affect patient care and patient outcomes. And for the most part, I think that you guys have done a great job in setting a standard for patient care. So, but you know, in response to this removal of the technician ratios, I'd love to believe that all employers will make that decision based on patient outcomes. You know, you talk about patient outcomes, and I'm a big patient outcome guy. I'm a root cause analysis guy. That's how my integrated practice is. Traditional prescriptions, compounded, we work them all together to get the best outcomes. But you know what? They don't. And you know, if we go on data, you know, you asked about data. You know, the reason that data is not out there is because, you know, we have a lot of prescriptions that are being misfilled, but we're not hearing about them because they're going into QA/QC portals that are safe havens. In order for a pharmacy to be able to decide whether or not it's doing a good job, they put it in a safe haven portal. Did you know that? So you're not hearing about those. So we have no idea whether these states that have no tech ratio actually have more or less misfills. But I think that we can probably assume that there's going to be bad actors out there. And bad actors, unfortunately, are in every profession, including pharmacy. And it's been proven over and over that when we let greed guide our decisions rather than intellect and care, patient safety and patient outcomes are gonna suffer. There's no doubt. I mean, let's just look at NASM, the FDA. FDA had to step in after a very bad actor in compounding killed a lot of people. But you know what? They had to decide to set their hair on fire once there was a horrible incident and a lot of people died. So in Texas, we're gonna wait until a bunch of people are injured and we have a lot of harm to patients because of this no-tech ratio, because of some bad actors who are not gonna do a responsible job of regulating their tech pharmacist ratio. Are you gonna wait for that? Matter of fact, I'm just wondering if patient harm cases in Texas increase due to medication errors, will the Texas State Board of Pharmacy realize greater legal culpability? I mean, you know, because these things are gonna start being reported, greater and greater numbers. And so I'm just wondering, has the board thought about that? So I'm just hoping that we can get a reasonable compromise on this. I love the 5-to-1 ratio. My pharmacy needs a lot of techs. We employ 35 people, and I have a lot of pharmacists, a lot of payroll, and obviously it's tempting to substitute a $15 an hour guy for an $80 an hour pharmacist. But I'm not that guy. And so, but I am worried about the bad actors. Thank you.
Thank you.
Good morning, members of the board. My name is Tyler Steeler, and I'm a pharmacist at Walgreens. I'm actually serving pharmacists in charge at a high-volume store in the local Austin area. I've worked for Walgreens for about 11 years. I've worked in the capacity of a certified pharmacy technician, pharmacist intern, and as a pharmacist. I'm here today testifying on behalf of myself, the TFDS, and Walgreens. So really the points that I want to make are just related to patient safety as they relate to the technician ratio. And as it's been mentioned before in this meeting, we've been at this juncture, or the profession has been at this juncture multiple times over the past several decades, with the first introduction of supportive personnel into our pharmacies within the 70s, to the institution of a limit in the early 80s of 2-to-1, and as it's crept up over the past several years. So throughout all of that, the opposition concern has been an overwhelming concern for public safety and the fact that the pharmacist would be unable to supervise any number of supportive personnel, up to maybe 2 supportive personnel, up to 3, and now 4. However, the safety concerns that people speak to have yet to be substantiated or observed. To that point, the NABP nationally does not support any ratio in their state model pharmacy act or any model rules that they publish. In addition to that, years of data collection states that have no ratio or have increased their limits do not support any harm to patients or any risk to public safety as a result of that. So it's been pointed out there are several states, 22 in the District of Columbia to be exact, that don't have any limit on how many technicians a pharmacist can supervise. And I don't want to discount the opposition. I understand way back in the 70s, whenever this was first coming about, the concerns that would have been present, given the fact that we're introducing support personnel don't have the same education as a pharmacist, and then considering that all the way up into the certification of technicians in the state of Texas in the late 90s, early 2000s, where we now require them to meet certain educational thresholds, there has not been any result of a patient error or medication error or patient harm due to those supportive personnel present or any given number of those supportive personnel present. And so I just simply believe that the concern, this is a risk patient safety, is unfounded. I just want to briefly close by reading a few quotes that I've gathered from other state boards of pharmacy members. The first comes from Mike Podrosky. He's the Pennsylvania Board of Pharmacy member. He says, I've been a pharmacist in Pennsylvania for 27 years and served on the Pennsylvania Board of Pharmacy for 15, 8 of those years as a chairman. During my tenure on the Board of Pharmacy, there was never a disciplinary case nor an allegation that came before us that alleged an error or patient harm was caused by too many technicians on duty in the pharmacy. The next quote that I'll read is from Hal Wand. He's a director of the Arizona Board of Pharmacy from 2003 to 2015. He says the process of establishing a new group of pharmacy workers and a reasonable ratio to pharmacists in the state of Arizona was a fairly long one. It took about a total of 15 years to occur, even though in retrospect it was a rather simple process. In 2008, the ratio was eliminated completely because no evidence existed that it had any effect on patient safety. And the last quote that I have is from Laura Shaw. She's a representative from the Michigan Board of Pharmacy. She says, I've spent 8 years on the Michigan Board of Pharmacy. Michigan is a state that has no pharmacist to technician ratio. In my 8 years on the board, from 2001 to 2009, I did not review a single case in either the full or the DSC that involved an issue pharmacist that encountered a quality incident involving too many technicians to supervise. The idea of restricting the amount of technicians a pharmacist can utilize in their practice setting works to the detriment of the patient and inhibits the pharmacist to provide care at the top of their license, since the technicians are there to assist the pharmacist and patient, but not to make decisions regarding patient care or any quality decisions. So in closing, I just urge the board to facilitate the advancement of pharmacy in Texas and eliminate the arbitrary ratio of pharmacists to technicians. Thank you.
Those quotes from boards, were there, I'm assuming there's a corporate affiliation? Is that how you were able to obtain those? Or?
So this is through an
Just
organization I'm a
randomly.
member of, that we have worked collectively together to assess the issue, and it's a point that I'm bringing forward, not from Walgreens specifically.
All right, any other questions for these two gentlemen? Thank you for your comments. Our next speaker.
Hello, my name is Tiffany Johnson. I'm the program director for our pharmacy technician program at Cedar Valley College in Lancaster, Texas. I want to speak to you all about how the ratio affects us on an academic level, as well as the lack of education. We have technicians that come to our program and need external training, and a lot of our stores, they will turn down our trainees because they don't have enough technicians to train them or to supervise them, or the pharmacists can't handle the additional technician, without the additional technician taken away from their duties. That ratio affects them at that level, so our trainees are being turned down from being trained because of the ratio. Also, we have high school students that are doing dual credit, and they're coming out of high school as a certified pharmacy technician. And increasing that role, a certified pharmacy technician straight out of high school would be concerning to me. However, addressing the additional training or advanced education would be a great idea for them. It allows those technicians to gain the respect of the pharmacists and that trust level, maybe from the board as well, to allow them to do more and take on more tasks to serve the pharmacists for patient care. The advanced education also affects our higher education because as a program director, I have to seek out qualified instructors to teach our technicians. And on the academic level, there's an associate's degree or higher that's required in order to teach at our school. And of course, a lot of technicians are not required to get that higher education, so we're limited in that area as far as hiring technicians to do the job. So this really leads me to ask you all two questions. Is this an opportunity for us to create an advanced level technician role? And also, is it a time for us to now require an additional or higher education for our technicians in order to take on more responsibility? Thank you.
Thank you. Any questions for?
Hi, I'm Laura Temple. Okay, I'm Laura Temple. I'm an independent owner in a small town. We fill about 500 plus prescriptions a day. In addition to 4 technicians, I have 3 clerks to run the register, run the drive-through, and do OTC stocking, all the various things that are not technically assisting the pharmacist. when I needed a larger staff, I added a pharmacist because that way I could have more time to do clinical outcomes. So when a technician brings over 40 totes to be checked, so each one will fill 10 at a time. They will bring them over to me to be checked. Now, that takes a long time to look at that and make sure I'm checking drug interactions, making sure, it was prescribed correctly, and we do the check tech. So we have one technician input, the second technician make sure it was inputted correctly. We do have automation that allows us to make sure we're pulling the correct drug, counting the correct quantity. We have all that in place, and still when it gets to me, sometimes there are errors that have to be sent back. So when I needed someone, I hired a pharmacist, and I am not in favor of getting rid of the ratio. I don't see how that's going to free us up to do more clinical. We're just going to have to take more prescriptions, and that's all.
Good morning, President. Good morning, President Spear and members of the board and staff. My name is Jeff Blush. I work for the Kroger Company as the Director of Pharmacy for our Dallas division and have been a licensed pharmacist in Texas for 17 years. I did provide a letter to the board outlining several key points. In addition, several of our pharmacists also voluntarily submitted letters to the board additionally expressing support for the elimination or changes to the ratio. We also had a number of pharmacists that traveled here today to show their support, one of which spoke earlier. David spoke on behalf of his personal experience and the experience of many of our pharmacists that they see day in, day out, and that is that they are routinely pulled away to do things such as data entry, product dispensing, and those are functions that obviously with the elimination or modification to the ratio are areas where technicians, additional technicians, can be of support, can allow those pharmacists to do more of the clinical functions, the things that we are progressively getting into in the field of pharmacy. However, the other point that I want to make sure to reiterate is to address the potential concerns over safety. To some, I think it seems like we're treading into unknown territory, but I think we do have the benefit of 22 states that don't have a ratio in place who have seen no impact. I also want to share that in my previous role with the company, I served as our senior manager over all regulatory compliance programs. And in that role, one of my responsibilities was supervising the management of our quality assurance program and reviewing all QA program data for the company. This included data for over 2,300 pharmacies in all states where we operate. That includes states with ratios and states without ratios. In our experience, we've seen no evidence of any diminished patient safety in those states without a ratio as compared to those with a ratio. Again, that's no statistically significant difference in our findings in the two sets of states. And I just want to thank the board for your time and consideration of these viewpoints. Appreciate your willingness to review the matter and for considering the impact that this decision will have on the continued development and expansion of innovative practice sites in Texas. Thank you.
Thank you. Any questions for this speaker? Thank you. Yes, sir.
Hi, good morning. My name is Thompson George. I'm a Director of Pharmacy Affairs with Walgreens. I also serve as the Program Director for our Pharmacy Technician Training Program. In my current role, I have a good feel for how this discussion has developed in other states, and I also have a good feel for the potential our pharmacy technicians have to assist our pharmacists. And I think there's been a lot of good discussion today. I just want to take a minute of your time today to talk a little bit more about the opportunity that you have here, and also give you comfort in maybe the decision that's in front of you right now. This discussion around expanding technician ratio or even removing the technician ratio altogether, it's not about mandating pharmacies to bring in unlimited number of technicians into pharmacies. That's not what happens. It's really about giving the pharmacies more flexibility. When there are more clinical tasks that need to be done, we have the flexibility to bring in another pharmacist. But if you just have some more administrative tasks to be done, we are limited at the number of technicians that we can bring at that time. So really, this is about, you know, giving the pharmacists more freedom to not be distracted, to focus on those clinical tasks that are ahead of them, and allow the technicians to assist in those administrative tasks. I know there's been some discussion today about, you know, workload, complaints on workload and potential distraction by pharmacists. You know, expanding the technician ratio would give you another avenue to help those pharmacists who need that support. And then talking about some of the concerns that have been expressed today, you know, there's a lot of what ifs that I think have been discussed today, and I think we've also looked at how this conversation has unfolded in other states. And I'm not going to really say too much more about it, because I think there have been good comments around this, but the fact is, you know, many states have removed the technician ratio altogether, and throughout that time, no states have revisited and reestablished the technician ratio. So if there was any significant concerns that had developed, I think you would see something different, but that's not the case. So appreciate your time today and your consideration. Thank you.
Thank you. Any questions for the speaker? Thank you so much.
Thank you.
All right, we are at, are there any other individuals that want to present? We are at 11:42. So why don't we go ahead, we're close enough, give everybody a little bit of time to digest. No pun intended, I guess. We'll have lunch and then we'll come back and continue with it. We're adjourned for lunch. Just 12:30.